The first person to survive Alzheimer's disease is out there. And the Alzheimer's Association is going to make it happen by funding scientific breakthroughs, advancing public policy, and providing local support to those living with the disease and their caregivers. But we won't get there without you. Visit alz.org to join the fight.
Okay, still morning. Everybody fired up?
Oh yeah.
Okay. So I introduce a friend, and I introduce another good friend of my world with Alzheimer's. When my wife was diagnosed, the neurologist said to us, "Your wife has Alzheimer's." I said, "What is that?" And they said, "You don't know what it is?" I said, "No." She said, "It's a brain disease of the brain with no cure." I said, "What do I do next?" "I don't know." I said, "What do you mean?" "No, I don't treat Alzheimer's." So my beautiful daughter helped us where we found that we could go to Houston, Texas for treatment for my wife at the Baylor Medical School. But God, in His infinite wisdom for helping me, they had a hurricane in Houston and flooded the Baylor Medical School. While that went on, a friend of mine was on the Board of Regents and introduced me to Dr. Bill, who informed me you don't have to go to Houston because do you know a gentleman by the name of Glenn Biggs? And I said, yes. Did you know he died from Alzheimer's? No. Well, he has been very instrumental, and we are setting up a brand new program in San Antonio for the Institute of Alzheimer's called the Biggs Institute. And we are in negotiations and are bringing the best of the best in San Antonio. The founding director of the Glenn Biggs Institute for Alzheimer's, Neurodegenerative Diseases oversees and activities of the Big Institute, Dr. Sudu Shashadre.
Thank you, Ben. This is my...
Feel the money. You have it there, Bob. We'll use this one question.
Thank you all. I'm so happy to be here in San Antonio. It's now 5.5 years that I came to set up the Biggs Institute and partner with people who were already here, like Dr. Patel, who interviewed me and was able to bring in many others. And about 2 years ago, the National Institute on Aging recognized us as the only Alzheimer's Disease Research Center in Texas, clearly a huge area of need. So today, I was asked to talk about Alzheimer's disease research and what's new, because we want to move from what Mr. Zinsmeier heard through the drive and dedication of people like you to where people will say, Alzheimer's, quick, let's diagnose it, let's do things because we can. And I know that this is a setting where there are some people doing continuing education, and I know that all of you are people who have a lot of knowledge and experience from different professions. So I'm going to try to tell you from a physician scientist point of view what seems the most promising. So what's new in our understanding of this disease, right? Sometimes you're told dementia, sometimes you're told Alzheimer's. What's dementia, what's Alzheimer's? We can see it. How are we diagnosing it these days? What's new in treatment and what's new in prevention? We already heard a lot about prevention and keeping a healthy heart and mind. So perhaps I'll focus a little bit more on the other one. We know dementia is here with reason. Partly it's the only disease that in the last 20 years has been going up in prevalence rather than going down. But I do want to say that part of this going up is because people are getting older. So at a given age, the risk is actually going down slightly because of many of these things, like being able to treat blood pressure, prevent stroke. No question it's a terrible disease, but we always recognize that the disease is occurring in a person. Tony Bennett, on the day before he died, had more musicality in his little finger than I will ever have in my life. So we are your partners in this journey through the illness for the patient and for the family. So what is dementia? The psychiatry book called the Diagnostic and Statistical Manual sometimes calls it a major neurocognitive syndrome. Simply put, it's a collection of things. It's a syndrome. And what does the syndrome result in? It results in a decline in your memory or different types of thinking abilities, planning, seeing, or changes in behavior because of changes in your emotional control, your empathy and understanding. And when it reaches the point that it affects your ability to do the things you want to do, the things you used to do, then the term for that is dementia. So dementia is a clinical diagnosis. You can make it at home if these things are there. But then what's causing the dementia? That's where you need to see a physician or a clinician or a neurologist to try and figure out what's causing it. Can you do something about it? And these are, the experiences of some people with dementia. Unfortunately, today, most types of dementia, we are not able to bring people back. So we know the stories from people who are going through the journey. Hopefully one day we will know it from people who have improved in memory and come back. So this question always comes, right? If you're over the age of 60, or sometimes even otherwise, am I having dementia? Why am I forgetting something? And the general thing we say is if it happens once in a while, that happens to all of us. The peak cognitive performance and speed is probably in your late 20s, early 30s, and then when you lose certain things, we make up for it by a richness of connections. The speed goes down. But if you're having frequent, persistent problems, yesterday we were talking to medical students and somebody was talking about his wife. They went and saw Schindler's List, and then as he came out, he was saying, you know, the symbolism of the red dress. He said, what red dress? So when something's so central, you're forgetting. You know, there was a birthday party a week ago, and somebody said, what? We haven't celebrated my birthday. Those sorts of, if it's persistent, it's frequent, it's affecting your ability to converse or meet responsibilities, versus, I can't get that name, but then 10 minutes later or half an hour later, that name comes back. Or you know, that is more like aging, and not getting it at all is more like dementia. But all dementia is not with memory or language problems. Sometimes it is, you know, not being able to make sense of what you're seeing. Sometimes it is sleep changes or walking changes, because there's a type of dementia that can begin with Parkinson's disease. So your doctor or clinician, nurse can go through things like this. Are your ability to make judgment, your ability to learn how to use a new gadget and maybe get a new TV or a computer, your ability to handle the financial affairs at the level at which you used to do, has that changed compared to a few years earlier? And they may do a simple set of questions. There are many of these kinds of questionnaires. And today we often recommend to those who are professionals the mini mental status exam, not because it's necessarily better than anything else, but because that's used to guide whether somebody can go on to a clinical trial or to one of the new medicines you've heard about. But anything that your doctor always uses, the big thing is the change from year to year. So starting at age 65, when you go in for a regular visit, Medicare is willing to fund and even requires some questioning and testing of cognition. And so if there's been a change, then that is what we want to talk about. And, you know, we don't like hearing bad news. So why bother, right? Why poke the bear? Why find out if there's some problem in memory? One of the big reasons is because a lot of the time something can be done to fix it and bring your memory back to where it is. Many times it can be de-prescribing some medications that may be affecting the memory. Sometimes it can be a sign of something else happening in the brain. Like maybe the blood flow is not okay because you have the first stage of a myeloma. Maybe there is something wrong with your thyroid. Maybe those are all sorts of different conditions. Maybe you're not communicating well because you're not hearing well, and a hearing aid is going to help fix that. So it's always worth facing, and you may be reassured based on blood tests and an MRI scan and just the testing that no, this is within the normal range. And in that setting, I wanted to point out a new entity, relatively new, it's been around for a long time, but something that is diagnosable and completely treatable is something called autoimmune encephalitis, where there can be antibodies. And what is the setting in which they happen? Often it's a slightly younger person, maybe less than 65, although it can happen to people over 65. The MRI doesn't look as harmless, you know. In dementia, one of the things, the MRI looks fairly normal other than being a little smaller, but these sorts of changes can be there. It can begin after something like the herpes encephalitis, where the person doesn't get better. It can be a sign of a hidden cancer somewhere. And one of the things we do is we do a spinal tap and we send off the fluid for testing for antibodies. And there are different types of antibodies that might be explaining this. If there's something unusual, the person is having seizures, they've gone down in a couple of months, when you call, try to make an appointment, tell the doctor this needs to be urgent because there can be something that could be treatable, diagnosable, and fixable. So, beyond the things that can be reversed, which we don't typically include under the term of dementia because they are physical, what causes dementia? It's a balance between the reserve you built up, right? Education is important. Education builds neurons. All the good things about during midlife, going running, swimming, having the right diet. We found there's something called the nun study, where nuns agreed to be tested every year and then donated their brain. And thanks to a recent recruit, Maggie Flanagan, the nun study brain and all this data is now here in our library and our district. So this is one of the places where they found that the 19, 20-year-old nuns, as they were entering the novitiate, the essays, if you looked at their vocabulary, if you looked at different things, that would predict who would get dementia and who wouldn't. So prevention of dementia, it's really never too early to start. Preschool may be a dementia prevention. So, and then on the other side, there are a lot of bad things that can happen. There's Alzheimer's, there's vascular brain injury, stroke, there's aging, there's a lot of football and PTSD and different types of trauma and stress. And then you have genetic resilience, and then those two acting together. But one thing I want to point out is that, you have a number of diagnoses that can cause it. Those ones in blue are the big common ones today. Alzheimer's is seen in about 60 to 70% of people who have these symptoms. But there's also something called dementia with Lewy bodies that I talked about later. There is, of course, stroke and vascular brain injury. And there's a recently recognized condition called late that I'll talk about later. Happens in older people, and the good thing about it is it seems to progress slower than the typical Alzheimer's. And so all of these together are called ADRD, or Alzheimer's disease and related dementias. And the Alzheimer's Association actually focuses on all of these ADRD. Now, there is a stage called mild cognitive impairment, where if you think something is wrong, on testing, you're perhaps performing not as well as you used to, or below what's expected for your age, sex, and education. But a lot of the time, mild cognitive impairment, while it could be the first stage of Alzheimer's, this is a stage where it's very important to get tested, because you might find a way to bring the person back to normal. This is something that researchers have clearly recognized, but I'm not sure that all, the whole community is aware. This is an example of 140 very generous brain donors. Only 2 of them, each color is one reason why somebody might have dementia. And only the first 2 in the left-hand corner had only one cause for their dementia. One person had Alzheimer, one person had vascular disease. Everybody else, you see that each bar is one person. There were 2 or 3 things explaining their dementia. So multiple etiology dementia is common. So we need to, if somebody develops dementia, don't stop treating their blood pressure or their diabetes, because they probably have that also as one reason, even if they have Alzheimer's. Alzheimer's, unfortunately, doesn't protect you from getting vascular dementia any more than having diabetes protects you from getting hypertension. So it's not a question of giving up because somebody has a fatal disease. We all have a fatal disease. It's called life, right? So it's a question of keeping that quality, slowing down the progression as long as we can. But when we say Alzheimer's disease, what do we mean? Alois Alzheimer described this way back in the late 19th century, in 1901. And you have these plaques that accumulate between the cells of the brain, and you have these tangles that accumulate within the brain, and the tangles gum up the work of the neurons, and the neurons die. Then there are fewer synapses, and these microglial cells seem to be sometimes good guys removing the amyloid, and sometimes bad guys killing the neurons. We need to bring all of this out. But the crucial thing is the neurons no longer talk to each other. The synapses are lost. and then memories can't be formed. So, just like, you don't wait for somebody to have symptoms of certain types of cancers, right? You do a prostate PSA and you say this is the first stage. So same way, a biomarker-based diagnosis became possible about 15, 20 years ago when a compound called Pittsburgh compound B was found to bind to the amyloid in the brain. Before that, it used to be, you would think, maybe this person looks like Alzheimer's is the cause of their dementia. But it was only when we got to see their brain that you could be sure that this was the cause. But the scans were called PET scans, and you can have a tracer that binds to amyloid. You can have a tracer that binds to the other protein inside the neurons, the tau. And then you can have MRI scans or other ways of telling that the brain has shrunk, and that's called neurodegeneration. So in 2018, the definition of Alzheimer's disease became if you have amyloid, tau, and neurodegeneration. And really amyloid and tau were needed. So now, when you went and did this in a group of older people, you found that many people had amyloid, but they were cognitively fine. So then the question was, what did that mean? And now what we think is that the amyloid deposition increases your risk of developing clinical Alzheimer's, but it's a pre-clinical stage. When you have that mild cognitive impairment we talked about, that is an MCI, that is a prodromal stage. And when you have the memory symptoms or other symptoms, that is clinical Alzheimer's. So the goal is, of course, can be by preventing this accumulation of amyloid, by preventing this accumulation of tau, prevent the development of the clinical dementia, which is the only thing we care about, right? I don't care if I have amyloid in my brain if it doesn't affect me all my life. So, with that approach, however, when somebody has dementia, how can you tell if it is because of amyloid and tau, that is because of Alzheimer or not? So one way, there's something called the blood-brain barrier that keeps bad things away from the brain. But it also keeps what's happening in the brain a secret, which is not easily found in the blood. And so what you have to do is a spinal tap, where you take out this fluid, you can see clear fluid coming out. That needle is not much thicker than what you put into a vein to drain blood. And that area is numbed up. So it's like going to the dentist. If you have decrease of this amyloid in the fluid, because all the amyloid is now gone and made plaques in the brain, so there's not as much of it in the fluid. Amyloid is something that we do need. And if you have high levels of the tau, because the tau has now broken out of the neurons and has entered the spinal fluid, and if you have a high ratio of the phospho-tau to the A-beta 42, then that, in the setting of somebody who has cognitive decline, suggests they have clinical dementia of the Alzheimer's type or Alzheimer's dementia. And I just want to reassure people tend to think, oh, lava puncture, that's a terrible thing. This is partly because for many years we used what was called a Quincke cutting needle that was designed literally in the 1900s. But for the last 10 years, we used an atraumatic sprout, which is not traumatic, just as we said. The edge of it is smooth, and because of that, it doesn't tear through the fibers between the bones. It separates them and goes in. We also are able to use bedside ultrasound, so that if somebody has had some changes to their spine, you can use that ultrasound to find the right space. One important thing, it's not that anybody can do this acupuncture. Many people, anesthetists, surgeons, ER physicians, all do acupuncture. But one thing to remember is you need to collect this in special tubes, because this amyloid is a very sticky protein. So if you just use plastic tubes, it sticks there, and then it will look like a low amyloid. So it needs to be done along with, it can be done by anybody, but it needs to be done with somebody who knows how these tubes need to be collected and sent off, and labs that are able to measure this. And I said that ultimately what happens is this amyloid and tau cause some shrinkage in the brain. And there's a pattern in which the brain shrinks. And what is that pattern? You see that red arrow? Now this little seahorse-like part of the brain, you see on the left, it looks quite plump. You don't see much of a black space. And that plump structure is the normal hippocampus. And in Alzheimer's, it shrinks. And this seems very important for remembering all those useless things we have to remember every day. Where did I park my car? That's not inherently an emotionally meaningful thing. Often people with Alzheimer's can remember emotionally powerful memories, like, somebody made me feel really happy and good, but not these kind of details which we are needed to remember. So there are ways in which we can rank this. People just look at it and say, this much atrophy of the cortex, this hippocampus is considered the medial temporal region. And then based on these, there are Alzheimer's disease signature patterns of atrophy and different types of qualitative scores as well as semi-quantitative scores. And now more recently, with, everybody is doing machine learning and AI, and you can have the computer look at your face and say who you are. So why not bring this into this reason? And so it's clearly coming to a radiologist's office near you. People already, we had recently some news about how Dr. Harvey said, based on these AI tools, the tools are trained by clinicians who say this is normal, this is abnormal, but then the tools can do it in seconds rather than in the minutes it takes for a human to do it. And so, another way in which this is something that Medicare does for. When you talk about PET, usually this is often the PET scan that's talked about. This is glucose that's taken up by the brain. And if a part of the brain, the neurons have died, then that much glucose is not taken up. So these parts of the brain, what's called the parietal region and the hippocampal region, those will have less glucose. And that's a fluorodeoxyglucose PET. That just tells you how much metabolism is happening. And on the right, these pictures are of, they're the other way around. So the red areas are where there's less glucose uptake. And so you can tell between the different types of dementia. It's not an all or none, but along with the clinical picture, along with the testing, you can use this to say somebody has Alzheimer's, so this part of the brain has less glucose, or somebody has dementia with Lewy bodies, so they're seeing visual hallucinations, and it's the back visual part of the brain that has less metabolism. Or somebody is behaving strangely, having language problems, and it's the frontal part of their brain that's having less metabolism. But coming back to today, I said we diagnose Alzheimer's based on whether there's excess amyloid in the brain. And so there are these tracers, different companies have different tracers, they're all pretty much the same, where you get a small injection. This is a tiny, tiny dose of radiation. It's not a dose of radiation to be afraid of. It's like the thyroid scans with radiation, radioactive iodine. So this binds to the brain, and then you take this picture. And this is a picture with the old Pittsburgh compound B that began this whole area of being able to tell amyloid during life. But then there are these newer tracers that are sort of longer acting. So these tracers are made in machines called cyclotrons, and the F-18 can be taken somewhere that's many miles away. And these cyclotrons are quite few places have them. UTHSCA does have one, but this could go, for instance, from here to Corpus Christi, and if there was a PET scan there. So if there's too much amyloid, that is Alzheimer pathology. If it's an intermediate level, there's a higher risk of Alzheimer pathology. And if you're having memory problems and there's normal amyloid, then we can say these memory problems are not because of Alzheimer's disease. We need to look harder and find another cause for that. The newer one, just about 2013, 2014, and FDA approved just 2 years ago, is flutoxetine, which is the same radioactive fluoro-18 bound to something that binds to the tau in your brain. There are different types types of tau. There's a type of tau that's specific to Alzheimer's disease, and this is the one that flutoscopy binds to. And so you can tell whether this is early stage where the tau is only in the memory parts, or whether the tau has moved to more of the thinking parts. And you can see progressively with more disease, more of the brain looks, that green and orange color. But there are some diseases that have tau in the brain but don't show up on this flutoscopy scan. These are non-Alzheimer diseases like progressive supranuclear palsy or corticobasal degeneration or some types of frontotemporal dementia. And for that, there are new tracers being developed all over the world, and by their company names, they're called MK for Merck or PI for Pyramid and some numbers. And we are part of the teams looking at these new tracers. Typically, we think amyloid builds up, and then that makes tau build up. But there are other things like just vascular disease. It sounds like women at the same age have a little more tau in their brain than men at the same age. And this is not seen in premenopausal men and women, but this is seen in postmenopausal men and women. So we don't know the cause. It may not be as simple as just replacing the estrogen. That was tried, big trial, and it didn't work. So now, if estrogen is replaced, this needs to be for symptomatic reasons, not to prevent dementia. But there's something about the postmenopausal body that seems to be perhaps increased with us. And everybody with Alzheimer's is not the same. You all know that, right? We all know people with Alzheimer's. Some people go down very quickly. Some people are fine for many years. Some people have memory problems. Some people can't see what's in front. So this is just an example of a type of Alzheimer's where it is called posterior cortical atrophy, where the problem is, if you, for instance, see, most of us, when we see a scene like this, we focus our attention on where the action is, on the pier or the beach. We don't look much at the water. The posterior cortical atrophy person is unable to do that guided scanning of a picture or of a real thing in front of them. So it's all one jumbly haze, and so they need help in telling the plate from the table or the switch from the wall. And the tau here is in the posterior part of the brain, the part important for object representation. So what we find is that the amyloid alone doesn't make the thinking and memory going down. It's when the tau builds up. And based on where the tau is, you can have posterior cortical atrophy, you can have an amnestic pattern, you can have a speech pattern, what we call logopenic progressive aphasia, and different kinds of things. And in addition to Alzheimer being quite diverse, there are other diseases I've been talking about a few times. I said dementia with Lewy bodies, frontotemporal dementia, and each of them has slightly different proteins in the brain. It affects more commonly certain different parts of the brain. And this is the new entity I talked about, limbic predominant, age-related TDP43 encephalopathy. TDP43 is a protein that's within the nucleus, has an important function, and when it kind of becomes balled up in the cytoplasm, it isn't able to do that function. It shrinks the hippocampus. The bad news is we know very little about it, and we don't know much about treatments. There's one older diabetes drug that's being tried. The good news is it seems to progress a little bit slower. Each of these things is seen in about 20% of people with dementia. So it's not really that rare, it's just poorly understood. So what's frontotemporal dementia? Some of you may have the unfortunate experience of knowing somebody with frontotemporal dementia. It affects language, behavior, mood judgment. People may start eating things that they've never liked. They may have ALS-like features because there's one of these genes called C9orf72 that causes both ALS and frontotemporal dementia. And there are some drugs we are trying that specifically act on that gene. And there is also sometimes Parkinson's type symptoms in these people. Aricept type medicines, this is the also one type of dementia where the donepezil may not work and could even worsen. Otherwise, if you think it's Alzheimer's and you give donepezil, most of the time it helps. And this is what the brain looks like. The front part of the brain can be shrunken. It doesn't have to be shrunken. If that's the part that's not working good, that's the part that on an FDG effect wouldn't look okay. But I do want to emphasize, we are people, dementia is a late onset disease. That means people bring a wealth of experience. Sometimes some of the changes in this horrible disease can actually be things one can celebrate. I've heard sometimes patients say, this person never paid attention to the family and now he's so grateful for all the time he has with me and the grandchildren. This is another piece, what they call the emergence of visual creativity. So this is well documented. Bruce Miller is a neurologist at UTHSCSA and his mother was a museum docent. This is one of his patients who was a weekend painter. Pretty nice. Above is her Japanese painting, below is her abstract art. But see what happens as she starts developing frontotemporal dementia. There's so much richness and emotionality. They think that when Bolero was written, Ravel was in the early stages of frontotemporal dementia. There is, as the language goes down, it's like the right half of the brain abilities go up. Just look for the small silver linings in this disease. Dementia with Lewy bodies, Robin Williams had it. It start off with just things like anxiety, depression, executive function, Parkinson's type symptoms, hallucinations, something called REM behavior disorder, where during normal dream sleep, that is REM sleep, our muscle tone is 0. So we dream, but we don't act out our dreams. But when you act out your dreams, when you hit your dead partner, because you think that this is a thief in the house, that can be an early stage of REM behavior disorder that can be about 20 years before the onset of Parkinson's or dementia with Lewy bodies. Symptoms like constipation, symptoms like dizziness, these can be early stages of dementia with Lewy bodies. And there are specific findings on scans that can help us diagnose. And this is what's called Lewy body, that little pig thing inside the neuron. And these are seen in Parkinson's disease and also in dementia with Lewy bodies. And then somebody asked about stroke. And yes, it's very, you can have big strokes. You can also have little silent strokes. You can also have changes to the blood-brain barrier. That is what this is. And just changes to the blood-brain barrier, even without amyloid, can also cause some cognitive changes. And these are the kind of things that we look for in the MRI. Now, it doesn't mean that if you have one of this in your MRI, you have vascular dementia. It just means you have vascular brain injury that could increase the risk of dementia. Things like white matter hyperintensities, lacunes, what are called microbleeds, those little black dots that you see. It's a special type of sequence. And classically, we say if somebody has vascular dementia, they can often get the words or the memory with some clues. They may be crying or laughing without actually feeling that emotion. They may have some weakness in one limb or slowness in the walk. But today we recognize that most people who have some vascular reason for having cognitive impairment don't have this whole thing. It's more that they have some injury and that's contributing. And there are many sensitive ways of picking up this injury. And the better and better the ways of picking up the injury are, the higher the proportion of people who have some vascular contribution. The risk of somebody developing high blood pressure during their life is over 90%. So all of us typically have some vascular contribution. So we say maybe the right question is how much vascular disease you have, even in people who have early onset dementia. So again, like I said, if somebody is having memory problems, this is not the time to say we are not going to treat the rest of them. it is the time to say we're going to treat their heart, treat their kidney, treat their lungs, so that their cognition will remain well as long as it possibly can. Another big question is, what has COVID done? Has it made us at a higher risk for developing Alzheimer's? We don't know, but we are working with Heather Snyder and others at the Alzheimer's Association and with NIH funding to help answer some of those questions. So if you are worried, we have studies here that you might enroll in. And the recent Alzheimer's criteria beyond amyloid and tau is looking at things like inflammation, vascular injury, this alpha-synuclein, which is the dementia with Lewy body protein, and we are thinking that the new criteria may include how much of each of these things you have based on biomarkers. And something that we are all eagerly awaiting is a blood-based biomarker, and we are getting there. There are some proteins that can go across the blood-brain barrier, and so their levels in the blood do reflect what's happening in the brain. And so some of these promising proteins, one is called p-tau181. It's just, you may just see some things in the news about it. It seems to be correlated with how much amyloid there is in the brain. One of my colleagues, Eva McGrath. And another is called p-tau217. Again, you see more of it in the people with Alzheimer's on the right of that graph, and less of it in people without on the left of the graph. And then if you take the top 25%, that's the top quartile, and the bottom quartile, you find that people with the highest levels of this p-tau217, that's the blue line, their cognition goes down fastest. So in 2 years, probably we may be able to, we're doing these now in a research way, and hopefully in 2 years we may be doing this as part of the clinical care. And looking at the genetics of Alzheimer's, we are now beginning to be able to do polygenic risk scores. Again, this is mainly a research thing now. In a few years, maybe something we do clinically. We have genetic counselors. Right now, they're mainly going to be testing whether you have one of these genes, like presenilin-1, the gene that was instilled Alice, where you have a very high risk of developing dementia. On the left-hand side is how big the risk is. On the right-hand side is how common the gene is. And there are many pathways. That's what these things are really telling us. So what's new in treatment? In 2019, at the Alzheimer's Association International Conference, I had this talk about how a personalized approach was going to be the future. Certainly an important part of this is amyloid. Amyloid is a protein in the brain, and it can break into these fragments. Usually the protein does something important. It's controlling what goes in and out of the cell. But if you get these fragments and they bunch up, that's when you get the plaques. And this year, there is one treatment, lecanemab, that's approved. Another called donanemab that will likely get FDA approved by the end of the year. But how much of a benefit do they do? They slow down the disease by about 4 to 7 months. How much does donepezil, that's been around for 20 years, do? It slows down the disease by 4 to 7 months. This is a benefit in addition to the donepezil. So you can be taking the donepezil and get this medicine. But these medicines are infusions, given once in 2 weeks or 4 weeks. Only about 5%, maybe 10% of everybody with Alzheimer's might be eligible to get it. Certainly less than 10%. And over 10%, as high as perhaps 25% of people, as they get it, particularly in the first 6 months, are going to get these kinds of brain swelling, what is called amyloid-related imaging of neurons. It's a very important, very hopeful step in the right direction, but it's just a small baby step, and unfortunately it's not for everyone. Certainly not for people who are being diagnosed later in the ages. So what is it? This one of these is something that acts on the plaque. One of these is something that acts on the stages before the formation of the plaque. and I'm not going to go over in detail, but what they do is that blue line is if you get placebo, and the orange line is the lecanemab, and it means that it takes away the amyloid from the brain. And in mice, when you take away the amyloid, memories improve. In humans, like I said, it improves, but very little. And so we need to make sure there's amyloid in the brain, we need to make sure there's not micro bleeds in the brain, because then the risk of a large bleed is higher. And we advise, this is still something that we need to discuss in each family, testing for the ApoE gene, which is a gene that increases your risk of Alzheimer's and also increases your risk of brain swelling if you're put on this medicine for Alzheimer's. Currently, Medicare has said they'll pay about 80% of the cost of the medication, which is estimated to be about $26,000 a year. We don't exactly know when to stop. And this doesn't take into account going to the hospital, getting that infusion and all that. So things will emerge, they'll be a little bit clearer over the next few months. But again, this is just something. Now, this study had about 12% of people who were Hispanic, only 3% who were African American. So we still don't know how well it will do in these settings. The other medicine, donanemab, 91% of the people were white non-Hispanic. So again, we know very little about how it will do in other conditions. One thing they were able to do in the donanemab was that people cleared the amyloid. They did repeated PET scans. So the thought is that they may be able to stop once the amyloid is cleared and then follow up and see how quickly it reaccumulates. We need better ways of preventing this horrible side effect, because if we could, then we could offer the medicine to a lot more people. So there's a lot of research now in trying to understand how we can stop this side effect of IRF. And like I said, there are many other things happening in the brain. So we need to see whether giving these amyloid removing medicines earlier is going to help, and we have trials doing that. And we also need to see whether other things, like improving the neuron's resilience, these are going to help. And so there are ongoing studies as well. This is not the time to say, oh, we've got an answer, we don't need to do trials. In fact, this is the time to say, oh, we are seeing a glimmer of hope. Let's persevere and push forward, because in the next 10 years, next 5 years maybe, we will have combinations, cocktails of drugs that are going to really make a difference. Prevention, I'm going to go through this quickly, just want to say the Nun study is here. Also, we have now got something called the San Antonio Heart-Mind Study, began in 1979. If you were part of the San Antonio Diabetes Study or Heart Study, we have folks reach out to you to come back and get the mind testing. You already know that there are many important ways in which one can prevent the risk of developing dementia. And one thing I did want to say, yes, what's good for the heart is good for the brain. Broadly speaking, it's not a perfect one-on-one. Even if you have a high genetic risk, these measures lower your risk by the same proportion. So if your genetic risk is 25% and you do all this right, it becomes like 12.5%. If your genetic risk is 5% and you do all this right, it becomes 2.5%. But I do want to say that while we agree with these things about the diet and the mind diet and the fish, there was a recent big trial of the mind diet in 650 people in Chicago, and the trial did not show a difference. People lost about 5 pounds of weight, but their memory didn't improve over the 2-year period of the trial. The reason I'm saying it is not to say diet isn't healthy. Certainly keeps your heart healthy, keeps you from having stroke. But don't go overboard. We still need to enroll in and see these trials. Maybe as we follow these people for 5 years, we'll find a difference between the two arms. Don't feel guilty. If a loved one or you has the disease or it is progressing, it's not that if you do all of these things right, you can absolutely prevent it. Unfortunately, we are not there. These will help. So I want everybody to do whatever they can, because this is the best we know now today. But not to feel, why did he get it? He did all of these things right. Because there are those additional things that we're just researching and trying to figure out. Okay? Physical activity is important. Preventing loneliness is important. In the early stages, that same drug, lecanemab, is now being offered to people with amyloid in the brain, preclinical stage, and no symptoms. So if you are interested and are over the age of 55 with APOE or over the age of 65, you can reach out to us and you get enrolled. And there are other kinds of studies going. This is the number. I think we have a table out there where you can learn how to enroll in this. There's also a website that you can just go, anybody at any age can go and register. And there are some, it doesn't cost you anything. It's just collecting information so that answers can be done. This is all over the country, and we are one site in both English and Spanish. And these are the reasons, the type of people who clinicians may refer for research. It could be because they're just interested in being part of a natural history study. We don't know much about how Alzheimer's or frontotemporal dementia. 5 years ago, people told me, oh, you don't get frontotemporal dementia much in Hispanics. Now we have over 150 people in just the last 5 years. So understanding our local circumstances is important. And this is a new building that you can see is coming up. And hopefully here we can provide that comprehensive care which we think everybody deserves and which you've heard about today. So Alzheimer's is a complex disease. Blood biomarkers are promising. Amyloid-lowering therapies along with other treatments will likely be needed. Prevention studies are needed to see what's the best ways of prevention and what's right for each person. One type of diet may be right for one person, another type may be best for another person. So everyone can volunteer for these. So thank you very much. We are looking forward to further events later this year and partnerships like with the Alzheimer's Association. Thank you.
Just wondering, is there any relationship between having tinnitus and with dementia and Alzheimer's?
Short answer is we don't know of any relationship that tinnitus causes dementia, contrary to those YouTube ads that you and I and everybody sees. Tinnitus is also something that happens with increasing age. It's more common in the setting of hearing loss and Meniere's disease. It can, some of the same things like a high blood pressure and diabetes can cause both tinnitus and Alzheimer's disease. Tinnitus is very uncomfortable, it can interfere with your sleep, but directly that noise causing Alzheimer's, there's no evidence that that happens.
Okay, one more over here.
My question was, y'all were working on decreasing amyloid. I don't remember how the talk comes about, but is there a way to work on decreasing the talk? Because it seems like the amyloid's not such a bad deal if you don't have the talk protein.
You have asked $1 million question. Unfortunately, we don't have as good ways of decreasing the tau. There were some studies even here of a version of methylene blue. So if we go back to one of the slides, there are medicines attacking both, and we are looking at some anti-tau, antisense oligonucleotide. You know that old story of looking under the lamppost because that's where you can see. So it's a little bit of, we are focusing more on the amyloid in some hope that as we lower the amyloid, the tau will not accumulate. It would be very good, and probably what's going to be needed for people who have both amyloid and tau in the brain is a combination of something that lowers the amyloid and something that lowers the tau. If you look at this picture, there are some agents, the red ones are the amyloid, and and then there are other ones towards the bottom that are tau-reducing agents.
One last question from online. How do you get tested for the amyloid? Did I say that right?
Right. So today, the two accepted ways of getting tested for the amyloid are either a spinal tap, where you can measure this ratio of p-tau to beta-42, or a PET scan. PET scan is beginning to be approved in certain settings. Like right here, we have a study called the New Ideas Study. Anybody who's Hispanic or African American, and a certain number of people who are non-Hispanic whites every month, we are able to work with Medicare, for Medicare to pay for their amyloid testing to be done. Otherwise, if you have 10 to 11,000 lying around, you can just get an amyloid scan. There is also hope. We are in a research setting doing these blood tests as well. They won't be perfect, but they will tell you whether your chances of having amyloid are higher or lower. And we are hopeful that in the next few years we may have blood tests that we can then do it like your cholesterol. But we aren't there yet.
All right. Thank you so much, Dr. They do such great work at the Biggs Institute, so thank you, Dr. Sachar, for taking the time. So, I am the only thing standing between you and lunch. So, I'm going to tell you a quick story. It started back in 1974. All right, we will. So, we're going to break for lunch. It is in the next room. We ask that you visit our care partners too while you're kind of getting in line and getting lunch. It's all in the center of the room. We have 5 different options. There's a chicken salad, there's a ham sandwich, a turkey sandwich. So there's a chicken salad sandwich, I'm sorry. A ham salad, a ham sandwich, turkey, right? English is my first language. A turkey sandwich, veggie wrap, and a grilled chicken, a salad with grilled chicken on it and ranch dressing. So for our restricted friends who requested vegetarian or something, so we would just ask that you please not take the veggie wrap unless you desperately need it. So make sure that we leave some for our dietary restricted friends. So you'll grab your drinks and your food, and we can come back in here, and we're going to be entertained by the bracelets choir. So,
Very nice.
right, so we'll see you all back in a minute.
Yeah, absolutely. Yeah. Sure.